Today's episode of the Stallside podcast was brought to you by Rood and Riddle Veterinary Pharmacy.
Bart, how are you doing today?
Appreciation for life. Things are good.
Yeah, things are great. Yeah, and speaking about appreciation, I think everyone's going to really appreciate our guest today, Dr. Fabrice Rossignol from France.
Yeah, I'm excited to have him in here because he does some novel surgeries in the upper airway, really pioneering and moving things forward with some horses that don't have many options.
Yeah, it's just a novel way of looking at things, and, tieback is a procedure that
been doing it forever.
Been quite familiar with, but he has an approach that actually involves maybe reinnervating the musculature of the larynx to give it more normal function under exercise, and the horse is better able to protect its airway. So this is going to be a great talk.
Yeah, I'm excited to have him in. Let's talk to him.
Yeah. So on Stallside this week, we have Dr. Fabrice Rossignol from France talking to us about some very novel surgeries to help the equine larynx function better under exercise. Dr. Rossignol, welcome to Stallside.
Thank you. Happy to be here.
Appreciate you joining us very much.
I'm very happy to.
So, Fabrice, tell us a little bit about yourself.
So I was boarded in the French school of Toulouse in the south of France in '94. And then I joined very quickly the clinic of Grosbois, that is East Paris, southeast. It's a training center with 1,600 trotter under training. And it's a lovely place with a castle. It was the castle of the General of Napoleon I. They switched it to a training center, so it's a beautiful castle, very close to Paris, 20 minutes.
Mm-hmm.
So I start from the very base by cleaning the box, cleaning the clinic, and then progressively start to continue my job like a practitioner, treating the race horses and some sport horses. And very lately, I would say after 8 years, I started the surgery. I start by self-made by dissecting legs and training. At this time in France, or especially in France, there was very few training, not residency did not exist. So probably due to that, I'm able to change things and invent my own way when I think. And I start with that. We should all do that by the anatomy, observing, dissecting, try to figure out how is the anatomy, the biomechanics, and then for sure follow the rules. But I think I was quite lucky to start without any teacher or mentor in surgery, so it makes my brain a little bit free and try. I hope that the horse were okay with that, but progressively I start. And very lately, meaning it should be 10 years after my start, I did alternate training residency, meaning it was at this time just 2 days a week, continuing my job of surgeon in my place, but doing a residency. It's long, it's 5-6 years compared to the current one. And then I was boarded after 6 years, and then I continue my job of surgeon. Progressively, I stopped doing anything else. I was, doing a lot of exam on the racetrack and everything. But I decided that to be good and to be better, I need to focus only on surgeries. So I have a full-time. I'm full-time surgeon in 2 or 3 clinics. And then I combine my activity of a surgeon with an activity of research, because I like to get a problem and try to find a solution. So try to say, why not doing like this? But don't do it like this immediately, but then make tests and some testing and some study until I'm sure that this would be something interesting to change, and then I go on. For example, in upper airway surgery, I think I should have been at the 40th version of my technique, because every time you have a problem, you try to think. And I was lucky to work with some very good friend and partner like Norm Ducharme in the US and many people. So we decided to share almost every month by what we are doing in research and everything. And I was lucky also to have a team because team is everything, and trying to share my passion with my team or with my residents. So I have many residents, and then they could help me in the research. So, in a private practice, it's not always easy to do a lot of research, probably 30 or 40% of my time, and then continue the business and operating horses. So due to the residency program and everything, I was able to combine everything. And then my plan was to share also things to other people, because when you do surgery, like specific upper waist surgery, or my other topic I like is orthopedics, fracture fixation. It's a smaller niche, so some group of horses. So if you focus only in your place, the case log is okay, but maybe not enough. So you can continue to improve and invent things. And I start to operate in some places in Europe. So I got 3 or 4 clinics, 5 clinics where I could, and now we were a real partner now. So it was a long story procedure, just keeping in mind the origin, meaning to try to invent things and develop and to stay in the scientific rule, meaning you need also to demonstrate and also you need to share, because sharing, you have more people who can do the things, and it's very grateful when you have many surgeons that, for example, today I saw a surgeon, I show you and I do the technique, etc. And also you can get some information and feedback and learn from them also. And all this life, I continue the same spirit, and I'm quite happy with it.
Yeah. Well, that's a very difficult way to do things, like to be working and then actually studying at the same time.
Yeah.
I mean, like people give up their jobs and fully commit to their education, and you've done both at the same time, which is very impressive. And you're quite right in what you say. Somebody has to look at things differently. Otherwise, we keep doing things the same. We may not be pushing the boundaries. We're not doing things the best. And you talked about like areas of concentration. You've done some very unique things with the upper airway. And that's an area that you're known for surgery. And one of them is reinnervating the equine larynx by using the nerves that were not originally there. So could you talk to us a little bit about that, please?
For sure. So the technique comes because the traditional technique is an efficient technique that's called laryngoplasty or tieback, and this is a technique. In horses, the disease is a hemiplegia, meaning it's just a progressive paresis of the left, usually the left side, meaning that the horse can only breathe from one part of the larynx, with only one part, the right side is abducting, not the other one. And due to the huge resistant impedance of air coming there and of airflow, then the membrane and everything is aspirating to the midline, and the horse cannot breathe enough to do the discipline of the sport it needs to. And then the traditional technique needs to fix the paralyzed artery, the left side, in a permanent partial degree of abduction. But the larynx is not used only for breathing, it's used for swallowing, for coughing. So it needs potentially to close and to abduct and to open according to the situation. Meaning at rest it needs to close to swallow properly. And at exercise it needs to abduct, but it needs to abduct fully, not partially. So meaning we treat a disease that with the larynx I need to close fully and abduct fully, to a blocked half larynx in an intermediate way. So
in a tieback, what you're saying is you're just
block.
You're going halfway back.
So you have
it can't all the way close, can't all the way open.
Exactly. Yes. So you have
left the door halfway open.
Exactly. So instead of opening the door or closing the door, you're opening halfway, and you cross the finger that it will be okay. But you can conclude that it's never perfect. So some horse manage to do the job and compensate, but is for sure it's a brutal technique, rude technique, and with many complications that can happen, and it's not your fault. It's just a technique, if you're a good surgeon. And what was quite frustrating is you finished. Sometimes we are so happy about the result with a nice abduction, but the trainer on the horse were not happy. It was not as you do. Sometimes you are not happy, and it was not so bad. It was difficult to anticipate the results, and the complication can be devastating. When a horse starts to be dysphagic, you cannot hide it. You see the horse in the morning and with the food in the nostril. Obviously, it's rare. It's not so common, but it's quite a difficult surgery. So for that, in an ideal world, you would like that the larynx is still able to close when needed and the horse swallow properly, and to fully or at least abduct significantly when the horse is breathing. So then came the technique of Reinnervation. So, for example, in a tie back, you replace a fully paralyzed muscle with a prosthesis, and you replace the muscle, meaning the muscle is not contracting, is fixed. And in a nerve graft, you graft a nerve that is activated during exercise on inspiration, at exercise only, and you graft it to the muscle to replace the nerve that is healed and diseased nerve. So an hemiplegic horse has a problem of the nerve, and the muscle problem is the consequence of the disease of the nerve. So meaning that if you take a new nerve, healthy nerve, and replace the nerve healed, you will, ideally, you will make the muscle working properly. And then you will stop all the problem linked to the fixation of the larynx, and you will have a movable physiologic. So to summarize, it's a physiologic treatment a potential physiologic treatment of the hemiplegia. And the tie back is efficient but quite rude and artificial way to treat this disease. But as everything is not white and black, so this technique is continuing. When you see the technique, potentially it's a dream, but there's some issue like everything in the nature. So to start, the technique was not invented by myself. It was start with Norm Ducharme and the origin in the 80s in experimental horses. When he tried one nerve, the first and second cervical nerve, that is a nerve activated at exercise, and he tried in experimental pony. And then another surgeon in Australia, Ian Fulton, operate a huge amount of horses, due probably to the type of horses they have there. And he had a lot of experience. And at this time, I decided to go further. And I was lucky to join a human surgeon that was the leader in the world. He's French, close to Rouen in the west of France. And he was the pioneer of laryngeal reinnervation in human. And as everything I told you, when you invent something in equine, if you go back to human surgery, these people, they have a huge amount of cases compared to us. When we speak about any fracture fixation, we are happy to have 200. They have 20,000. So to get feedback and opinion. So I was lucky to do some surgery with him and get his feedback and advice, and then progressively, I adapt what I learned from my peer, with Professor Ducharme and Ian Fulton, and then I try to refine a little bit the technique, and month and year after years, we smoothly improve the technique. Mm-hmm. And the success rate, to make another point, story that, for example, to show you where they are in human, this friend, the human surgeon, text me 3 weeks ago that he did the first successful larynx transplant in a human in Lyon. So meaning that they took a larynx for someone and grafted to another one with all the nerves included. So meaning that you see where we are. So so to do that, there's no limit to our improvement. But to do that, we need to be very objective. It's not because the idea is good that the results are good. So you need there's many limiting factors, and step by step, you need to find what is the limit of 100% of success and how you can refine the technique. And it's where we are. Mm-hmm. After the last 10 years, I would say we are continuing refining the things, and especially today with all the group of nice surgeons, you can share with your colleagues and get new ideas and then continue the job.
So transposing this nerve, this sounds like very delicate surgery, and you're working with very small structures. How do you do this?
So the first thing is, yes, you need to choose a good nerve. And surprisingly, the first nerve was the one that was originally built. But this nerve, when you as you say, was quite small and very variable. For example, you can get one horse with I would say, strong, big nerves, nice nerves, and some horses with non-optimal nerve. So this variability was a little bit frustrating. And secondly, I got an idea to find a new nerve, and for that I observed horses on the racetrack, and I could see that some muscle of the neck was contracting, especially the muscle that is called the sternocéphalicus or sternomandibularis, the muscle that is allow the horse to flex the neck when galloping. I just found that this muscle visually was contracting at the same time that the horse was breathing, inspirating. So I said, what is the nerve? So I do some dissection and then some EMG test, and we could realize that this nerve was exactly activated when the horse was breathing, because when you see a horse galloping, every time he's making his inspiration, he's flex the neck like this, So the first idea was to if you take this nerve for this muscle and we graft it to the larynx, probably we could have a good effect. And this nerve is really strong. So we have a new nerve, we prove it with many study, EMG, testing, etc., and then experimental things. And then we graft the two nerves. So these two nerves, they look very delicate, but, once you know where they are, when you dissect them, it's not as difficult. It's just training, just learning curve. And the beauty of this is I do all these things standing, with the horse standing, and local anesthesia. I don't do any GA in tie back, so all the horse are awake. So they are looking at you and you do the gap. So the beauty of that is all this surgery, you don't do any general anesthesia anymore, at least at our place. And so the combination of this natural grafting surgery technique, plus the fact that you don't have any GA, any general anesthesia, for an owner is good because the risk is extremely low. It can only improve. And so this is the way, and the technique is delicate, but the fact to do it standing make that all the structure are very mobile. You can move them. A larynx in a normal horse, you can take it and move it almost where you want, compared to a horse on general anesthesia, where with the tube and the weight of the horse, and all these muscles that are flaccid and with gravity going down, is a little bit difficult. So due to the fact I'm doing standing, I can rotate the larynx towards me, and so all the structure are visible like it was in an anatomic specimen. So the job need to be learned, but to be honest, is not as difficult due to this. Probably also the fact that we are doing it standing.
That is incredible that this can be done standing.
Yeah.
So the horse is under sedation.
Just sedation and local.
Yes. Yeah.
It's incredible how they are relaxed.
That is amazing.
Yeah.
Yeah.
Wow.
So what's the ideal candidate for this type of surgery?
That's an excellent question, because I think nowadays that the success rate of this technique is related to the case selection. Because recurrent laryngeal neuropathy or hemiplegia is a progressive disease that starts in the early age and progressively go to inevitably to the total paresis of the muscle. But the problem of when you graft a nerve, you need to have a muscle that is able to be a good receptor, to accept the nerve and to go back to a normal function. And some people who have paresis or unfortunately or injury of the nerve, they can recover, but after a certain amount of time, despite of a good healing of the nerve, they cannot get the muscle back because this muscle, when it's totally paralyzed after some months, it becomes fibrotic. Fibrosis means that there's some fibrosis inside, some collagen, that prevent any contraction. It's like a dead muscle. And in T0, when you start, you need to anticipate that your nerve will be okay after 6 months. And it's going fast, the degeneration of the muscle. So the success rate of this technique is dedicated to the early detection of the disease. And the problem is at the early stage, the horse is making noise, has some problem, but it is not so bad. So many vets or less but owner want to wait and see. And then now the horse is not able to do the job anymore. And then they ask the vet, please, I will do the surgery, and it's too late. So it's education, showing that anticipation of the problem. So to do that, we need to prove that a disease, early disease will inevitably go to a end of the muscle. And we are doing study of that, and we showed in a homogeneous group of horses that at least 80% with the early grade of partial paralysis will inevitably go to a late grade with fibrosis of the muscle. So you can advise the owner or vet that let's go now, because I can promise you that this horse will inevitably get the disease worse and worse. And then we need to be able to diagnose this. So due to the development of the new technique, like the exercising overground endoscopy, we can detect this disease early. And also due to the echography of the larynx, ultrasonography, that is matching very well with the overground endoscopy, we can diagnose easily very early. So the advice we give now to the owner, that as soon as he can hear some noise, he need to anticipate, ask him vet to do an exercise endoscopy and an ultrasonography, and if the disease is diagnosed early, then the nerve graft will be an option and will probably work. And the problem, we were so enthusiastic at the beginning of the technique, we were probably grafting too much advanced horse with advanced disease, and it was too fibrotic. So now we go back to a more accurate and case selection. And to make it short, the yearling, the very young 18 months race horse, are the good candidate. They work almost all. The young 2-year-old thoroughbred also at the early grade. When you have time, because you need time, you need the graft will not work the day after. It will take 6 months to work. So if the owner wants the horse to be okay in 2 months after the surgery, it's not possible. And so you need to anticipate the duration. And the young horse, they have time. And the young sport horses, also at 3-year-old, they have all the career. And we talked before about the complication. And the complication of tie-back, for example, the longer is the career, the higher risk you have to get a complication, because it's not a complication that always happens at 1 year, but it can be 1 year, 2 years, 3 years. This horse can have lung problem after being slightly dysphagic, etc. So in all young horses, when you have time, it's a very good indication. If the horse is advanced in the disease, and when you can see in the ultrasonography some fibrotic lesion of the muscle, you can try, but probably it's too late. The thing is, you have no risk. If you do that, even if it doesn't work fully, you can still do a tie-back after. So it's not something that you injure the larynx in a way that you can do. So you have always a plan B. So why is not trying something physiologic and riskless and see, and after do a tie-back if needed. But to be very accurate in terms of case selection, to summarize, very young thoroughbred and young sport horses at the early stage of the disease. And another good candidate, tie-back can be a disease, or hemiplegia can be a disease or can be an accident. For example, you have some horses that can develop an hemiplegia after an injection or after a trauma. And in this situation, the muscle is not getting atrophy like the disease. So in this situation, the muscle is healthy for a very, very long time. So in these horses where the disease happened due to an accident, an injection, trauma, neck stretch, and everything, then this is also an excellent indication of nerve graft.
You mentioned diagnostic ultrasound. How quickly do the ultrasound changes happen as this disease process begins?
So it's a good question. Experimentally, if you create a neurectomy of the nerve and see, it has been done in the past to see how long it's 3 months. So it's quite fast. But in a natural occurring disease, the disease starts very early and sometimes you don't see anything. So you can see very quickly the beginning of the disease, very, very early. You have 2 muscles that you can ultrasound. And this is a very accurate technique of early detection of the disease. And it's a very quick learning curve. This is the first advantage of this echography. Every vet have an ultrasound. This is the exact same probe that you use for checking the tendon. So that's the same. So you don't need to buy anything. And for a vet, and also the big advantage, there's 2 sides. So if you have any doubt, you compare the left side to the right side, and you have a good standard, and you know how similar it is. So even if you are not used every day to do that, it's an easy procedure because you can compare to the other side and have an accurate disease. So more and more with this kind of course, like today in Rood and Riddle Hospital, young surgeon or surgeon can be trained very quickly with this technique. And I think that in the future, due to the development of this diagnostic methods, the disease can be detected early, and probably while we continue to improve the technique of nerve graft, the global success rate should increase.
Yeah, that's just fascinating stuff to be able to detect that with the ultrasound and say, hey, let's just reinnervate that with your observation that this contracts at the same time as the horse is breathing. Because I was trying to get my head around how did you pick that nerve? That makes perfect sense, and it's just power of observation.
Yes, for sure. It's everything is the same. You need to. The nature is so beautiful. It's so well done. So as soon as you observe the nature, everything as a whole, and that's what's funny. If you look at a horse galloping, you will see immediately which muscles are contracting when the horse is straight. And if you video that in a slow motion, you can pick when the nostrils are opening, which muscle in the neck. And then as soon as the nerve is long enough to be transposed, and it was the case, then you can transpose it. So we are not at the end. We are just refining and continue to improve every day. But the concept makes sense. And we just need to continue to find tips. For example, recently I realized that some not successful enough case, I would say, not unsuccessful, but somehow that are successful, but probably not enough to do the job perfectly. I realized that the technique itself, when you open larynx and then check the muscle, you have scar tissue after anyway. And this muscle, contrary to a tie back, where you don't care that the muscle is not moving after because you fix it. But this, you need that the mouth keep movable, mobile. And then with the approach, we are opening a fascia or something. And then at the end, when you put the nerve, I realized that there was scar tissue at the end. And just changing the technique, doing another approach without opening this fascia, we preserve the mobility of the muscle. And I strongly believe that will also change the life and the success rate of that. Some details, you don't think about it, and suddenly you realize that if you do a very nice arthroscopy of the horse with removing a fragment, and then you cast the horse, you will say that he cannot move the fetlock. And sometimes with the fibrous tissue, you can prevent the muscle to move properly. So just by adaptation, refining the technique, we continue to have a new idea. And this reason why we like to be honest with our mind, not to overestimate our success rate, not to be also sad when just doing the solution for failure, hopefully rare, but when it's happened, how I can improve. And then it's lovely to see my resident just send me some feedback. Then we can see that you can see a learning curve and progression of the success rate of that. But the theory is good, and is our role to continue to improve the efficiency technically. But as everything new, when you look at how the plane 20 years ago and now everything changed and improved.
Yeah.
You need to be a team. You need to continue to work, to be passionate by this, and share with friends and share with colleagues, and continue to.
Yeah, because it's always been my worry. Because I see some of these horses post aspiration pneumonias. How do you, when you're tying, how do you know where to put it? As you say, it's a compromise between the airway open, the airway closed, and it's fixed. Whereas this, you give a chance to, as I say, restore a little bit of function, and the horse can protect its airway.
Exactly. Yes, it's a good.
Good which makes perfect sense. It's technically a whole lot more difficult, but this is really exciting stuff.
Yeah. The big thing is if you do it standing, the horse is positioned as it will be definitely. He has no tube in the throat. The neck is not twisted, so you can adjust by millimeter exactly, and then you can make him swallow and check before you knot your suture. So you fix it, and then you move a little bit the scope, and you see the other side, and you just you check that the right side is able to compensate by overclosure and compensate to close the glottis. And as soon as you are not sure of that, you don't knot. And then the fact you do it standing, you have the horse is like it will be the day after. So you are in normal situation. So at the beginning when we did standing tieback, we just did it because we want to remove the risk of general anesthesia. Because, for example, in Europe, we have thoroughbred, but you have also with this big warm blood, 600, 700 kilo, that are also at risk of general anesthesia. Mm-hmm. And in US, in Cornell, New York, it start that because of the draft horses that have a lot of hemiplegia. So we start for another reason. We start because we didn't want to do GA, and we realized that it was possible. And just after we realized that it allows us to adjust the fixation properly, more we think accurately, due to the fact that the horse will be exactly in the usual situation he is with the throat and the neck.
Impressive stuff.
Yeah, that's great. I'm curious with the other surgery, what you said about 6 months, if they're going to be successful, then you have full function, correct? What's aftercare? When did those horses go to work? And
another excellent question. You are a professional. No, because you're right. The problem is when you do a surgery, the tendency of the owner or the trainer is to rest the horse.
Yeah.
And the problem is that when you rest, as I told you, this nerve is used for flex the neck at gallop. So meaning that this nerve is activated at exercise. So if you cannot get any bodybuilding looking on the TV with a beer, you need to, if you want to develop your musculature, you need sooner or later to go in the fitness room. Mm-hmm. So the problem is when you graft, if the horse is not trained after, then the rehab will not go. And the problem is you need to stimulate the trainer of the horse to train the horse in order to rehabilitate. It's like a horse come back to the field without any back, any musculature of the back. He needs to work, and he will not get this muscle in one day. So that's a weak part. And looking back, probably some of our failure is also because the horse is not properly trained, I would say. The main reason is that the horse is still making noise a little bit because it's still not functional. Then the trainer can be a little bit stressed about activating, and the horse can change of trainer, etc. And so that's a limiting factor also. So it's also a good point, and you need to educate the people and follow the horse. So what we do, we call them, because sometimes you explain that the day, and these people are 20 horses on training, and suddenly this horse is making noise, it's hopeless. No, I explain you need to train to rehab. So progressively the one that follow you, most of the time it's a big advantage. So it's also a case selection. If you feel that the trainer or the owner will be a little bit simplistic in terms of training, etc., maybe you shouldn't go, because after you will think that you get a failure and it can be a success. So, advice and rehab is important. Like in a fracture, look at a tendonitis. When you have a tendonitis, you can expect that the horse will be back in 2 months without any rehab. So the secret is to convince that getting a renovated larynx back to training and sport is the same as to get a tendonitis and to rehab. So to advise, and as we did a lot of electromyography on this original muscle, the muscle of the neck, we know now exactly which movement. For example, if you lounge on the opposite side, there's more activation, etc. So you know exactly the map of training we need to help the trainer or the owner to properly rehab this muscle. So that's
very
exciting.
Yeah, it is, because the tendency you think, oh, major surgery, let's rest it.
Let's go to the field.
Yeah, but that's, as you say, you need to put them back and work and get that muscle working like it is. That's fascinating stuff.
Yeah,
wow,
it is. Yeah. So what kind of a success rate, or proper case selection? Where are we at? Because I know that you're still, fine tuning things, but
so to be very honest, I think in a proper case selection, we are around 70%.
And you would define success as
by horse free of clinical sign are able to do the job.
So be able to do their job.
Yeah, 60 to 70. The more we select, the more success we have. So it's all together. Meaning that if it's unsuccessful, it's just that the horses still have some problem with noise. Yeah. It's not a disaster. Mm-hmm. If we combine that to the result of tieback, that should be around 60% for race horse and probably 80, 90 of sport horses, the failure is sometimes a big problem that has not always a plan B. So the advantage of the unsuccessful nerve graft, you can still put a prosthesis. So what is the risk, to try, except the cost? But if you remove that and do the best for the horse, it's good to try to renovate the larynx, because especially as we do it standing, you have almost the risk of getting an injury during the surgery, etc. So I would say probably the success rate is, I would say, so far only 60-70, but unsuccessful is just the horse is a little bit better, but not enough to do the job. And we don't know if more training will do. Mm-hmm. For example, I have a story that 2 horses coming from England, I did a nerve graft, and after 6 months, I scope the horse and I say that I'm disappointed to the trainer. I'm sorry for that. For me, it doesn't work. It will not work. I propose you to do a tieback now. And he said, no, I feel the horse is more happy. Whether he's more happy. He's happy on the racetrack. He has me to go. If he's happy, I know my job. If he's happy, he will go. Then he refused to do that. He continued, and the horse was successful after 9 or 12 months. So sometimes you don't know. It's very difficult to assess the success rate with a multi-factor, because you can have a renovation, but the owner is not happy because the horse is not performing. You can have a successful nerve graft and rehab, but the horse is still making noise, and the guy correlates the noise on the. You have many reasons. So it's extremely difficult to conclude anything. What we see is that this technique is physiological. We are at the beginning, and we're continuing refining this and try to improve it. We are lucky to get feedback also from humans, where they're also improving every day. And also that the risk of failure is just unsuccess, but is not a complication that lead to lose your horse or lose your quality of your horse. And the plan B is what you expected at the first line. So it's for me it's a step that makes sense. Right. But don't be a dreamer. In a 8-year-old sport horse with a complete paralysis, nerve graft is not an indication. And for this middle candidate, now you have a fuel car, a lot of US, we have electric car now, and now you have hybrid car. And now what we do, we combine both. So we combine a safe tieback, I would say minimal opening. So the horse is blocked in resting position without the risk of getting dysfunction, and we add the nerve graft. So we are now developing in collaboration with Cornell and Norm Duchamp what we call the DNP, dynamic neuroprothesis, meaning it's just a combination of the tieback without the potential complication of dysphagia, because we don't open fully. And the nerve graft without the complication of the nerve graft, meaning that the horse is still half improved. So the trainer can train him because he doesn't listen to noise enough. And then it's a balance. And in some case selected in the middle, not to the yearling and not after, we put half and do this technique also. And this we have some very promising results so far.
Okay.
Very impressive.
Fabulous.
Yeah. I mean, again, and it's trying to restore more normal function.
Yeah.
And it's just like fascinating your approach and exercising these horses, not resting them. Because, I mean, a failed tie back is bad.
Yeah, the felt back can be bad.
Yeah, right. That could be just, you have to cut the suture and then you've
it's
got
bad.
less than you started.
Yeah, it's bad in two ways. It can be infected. If it's dysphagic, you need to remove or to relax. But then you relax, it will stop to be dysphagic, but you will go back to the first line, meaning it makes noise and it's not okay.
Yeah.
And if it's not losing abduction, it's not so easy to restore the abduction, because if it didn't work the first time, meaning that the cartilage may be a little bit weak, and then the cartilage should be weaker now. So I don't say it doesn't work, but most of the time is not written. You might have a second failure. Plus, as I told you, the tissue there's scar tissue, fibrosis. So technically, it could be very difficult. So the plan 3C is removing the cartilage here, which we call a partial arytenoidectomy. So it also has some success, but as we expect, when you make an amputation of the larynx, you can have a good successful, but you can also do into complications. So I would say the logic is to be less aggressive and then progressively more aggressive to balance the success and the risk factor to give the horse the big chance of success in a benefit-risk way.
Yeah, I mean, that seems logical, right? Try to restore function. If you can't, then you tie back.
Yep, makes sense.
That's great. Well, we move forward because great minds are curious, and yours is no different. Appreciate that you're looking to give some of these horses that really don't have much hope, some hope, and that's what we do. Appreciate what you're doing.
Thank you.
Yeah, I just like your approach by using like physiology to actually solve a surgical problem and just try to make the horse more normal. So, thank you. It's this isn't what I do, but I'm very fascinated by what you've just told us.
Thank you. And probably in 3 years, we have more things and more improvement. That is the beauty of our job, is to continuously improve.
Yeah. And that's Stallside for this week. We've been with Dr. Fabrice Rossignol talking about some very novel surgeries to reinnervate the equine larynx. See you next time.